Hello, and a very warm welcome to this Obstetrics and Gynaecology podcast on ectopic pregnancy. This podcast is produced in association with Oxford University Press and is based around a chapter from a new textbook in the Oxford Specialty Training series that is entitled Training in Obstetrics and Gynaecology, the Essential Curriculum. During this podcast, we shall be discussing ectopic pregnancy. This is an important gynecological emergency that it is very important to get to grips with early in your training. It's a condition that you will certainly see in your O&G attachment, as well as in A&E and occasionally in the setting of general practice. We shall be looking in this podcast at the important definitions and epidemiology of ectopic pregnancy, talking about its classification, presentation, and then finally talking about the essence of management for this condition. So, let's start with definitions. Ectopic pregnancy may be defined as the implantation of a pregnancy in a site other than the endometrial cavity. As already mentioned, it is a common condition affecting up to 20 in every 1,000 pregnancies. Importantly, the incidence of ectopic pregnancy is rising, and this is partly due to an increase in detection rate because of better resolution ultrasound, but also because of the increased prevalence of pelvic infections, which, as we'll go on to see, is an important risk factor. It is also important to note that ectopic pregnancy is the leading cause of maternal death during the first trimester. So, you may classify ectopic pregnancy into tubal ectopic pregnancy and other. So, by tubal, we mean that the pregnancy has implanted within the tubes, the fallopian tubes, and this accounts for the majority, about 95% of cases. In terms of where the ectopic implants, it's important to note that ampullary is greater than isthmic, is greater than fimbrial, is greater than interstitial. Other accounts for other sites outside the tubes, and important ones to be aware of are the cervix, the ovaries, and sometimes in the abdomen. When we're considering the pathogenesis of ectopic pregnancy, there are a couple of important things to be aware of. The most important of these are the tubal factors. This essentially means that any damage to the fallopian tubes, say secondary to surgery or infection, increases the risk of ectopic pregnancy. And in fact, ectopic pregnancy has been shown to be 10 times more common in women with a history of pelvic infection, such as chlamydial infection. It is also important to note that chromosomal factors can play a role, and chromosomal abnormalities in a developing fetus are predisposed to ectopic pregnancy. Finally, hormonal factors have also shown to be important. Progesterone is particularly one of these and has been shown to decrease smooth muscle contractility, and it is therefore thought to predispose to ectopic pregnancy. The clinical presentation of an ectopic varies greatly, from mild pain to massive hemodynamic compromise and sudden collapse. The key symptoms to be aware of are pain and bleeding. Pain may be either unilateral at the site of the ectopic or after perforation generalized, and often shoulder tip pain is described in this setting. Bleeding occurs in up to 75% of patients presenting with an ectopic pregnancy and is usually quite mild. Possibly the most important thing to be aware of is this. Any woman presenting at a reproductive age with a positive pregnancy test together with abdominal pain should be considered to have an ectopic until proven otherwise. So, what are the important signs of ectopic pregnancy? Well, first of all, as we've said, patients may present in extremis with severe hemodynamic compromise due to large blood loss into the abdomen. However, more commonly, they may present with an acute abdomen. There may be tenderness over the site of the ectopic, and if hemoperitoneum occurs, there may also be rebound. If blood is present in the pelvis, cervical excitation may also be present. So now we're going to go on to talk about the most important management principles for patients presenting with possible ectopic pregnancies. As is the case with all management, it is first important to resuscitate the patient with respect to the airway, breathing, and circulation. Circulation is particularly important here, as patients presenting with possible ectopic pregnancies may deteriorate rapidly. They should therefore have large bore IV access established, be given fluid resuscitation if they are hypovolemic, and have blood cross-matched. When we're thinking about investigations for patients presenting with possible ectopic pregnancy, we can use our usual investigative sieve. So under dips and cultures, obviously we want to do a urine pregnancy test. Under venous bloods, a full blood count will be important, and group and save and cross-match. User needs, our LFTs, are important to establish renal and liver function, and we'll come back to why this is important later. And serum beta HCG and serum progesterone are also important for cases that are not immediately obvious on ultrasound. We'll come back to this in a minute. The most important test, probably apart from obviously a urine pregnancy test, is an ultrasound. However, while many ectopics will appear on ultrasound, 10 to 50% of ultrasound scans will be inconclusive, i.e. they will be unable to distinguish between an ectopic being present and an ectopic not being present. If we consider scopic or biopsy techniques, laparoscopy may be used both for diagnosis and also for treatment. So let's consider the management in a little bit more detail. So as we've already said, with the presence of pregnancy and pain, you should always consider ectopic pregnancy. The most important first line investigation will probably be ultrasound examination. And this may tell you that an ectopic is indeed present, and it may tell you with some certainty that there is no ectopic present. However, as we've said, up to 50% of the time, there will be the possibility of an ectopic, or we might say that an ectopic might not be able to be absolutely excluded. In this setting, if the patient is unstable, then they probably do have an ectopic, and they therefore go on to have treatment. However, if they are not unstable, they tend to be monitored clinically. And the key things to be aware of here are the role of serial beta HCGs taken 48 hours apart, repeat ultrasounds, and serum progesterone. So, in terms of serial beta HCGs and progesterone, there are a couple of rules of thumb to be aware of. If the beta HCG is greater than 1,500, then any pregnancy should be visible on ultrasound. So often, patients are monitored until their beta HCG gets greater than 1,000, and then they have an ultrasound. Normal pregnancies should also double the beta HCG every 48 hours. And this is the reason that women are often admitted for 48 hours for serial beta HCGs, and if they don't double, then an ectopic pregnancy is highly suggested. Progesterone may also be helpful in deciding whether a pregnancy is failing or ongoing, with a value of less than 20 suggesting a failing pregnancy and one greater than 60 suggesting an ongoing pregnancy. However, it is very, very important to be aware of the clinical state of the patient. If the clinical state of the patient deteriorates, then one should move to laparoscopy for definitive diagnosis and indeed treatment. When we're considering treatment for ectopic pregnancy, you can divide it up, as always, into conservative, medical, and surgical. We've already talked about a few of the conservative things, such as fluid resuscitation. If the lady with the ectopic is in pain, you might want to consider giving analgesia. And obviously, if there is any possibility of going to surgery, then you would want to make the patient nil by mouth. The most important medical option for patients with a confirmed ectopic pregnancy is the drug methotrexate. However, there is a specific set of criteria for which this may be used. So, for patients to receive methotrexate, they must first of all have no altered renal or liver function, and this goes back to why we initially in our investigations measured the user needs and the LFTs. There are three other conditions that are also important. The ectopic should be small, so less than 3 centimeters on ultrasound. There should be no perforation of the tube or no hemoperitoneum, and the beta HCG should be less than 3,000. If all these conditions are met, then success with methotrexate may be up to 90%, but it is very important that follow-up beta-HCGs are taken to ensure resolution. The two most important surgical techniques are both laparoscopic and include laparoscopic salpingectomy and laparoscopic salpingotomy. In laparoscopic salpingectomy, both the ectopic and the tube that's been affected by the ectopic are removed, while with laparoscopic salpingotomy, the actual ectopic itself is removed but the tube is left in situ. This technique is particularly used if there is damage to the other tube and fertility is required to be maintained. The prognosis following a single ectopic pregnancy is actually quite good, and 70% of women will go on to have an intrauterine pregnancy. However, there is a 10% risk of recurrence, and it is important to be aware of this. So, in summary, in this podcast, we've talked about ectopic pregnancy, which is a common gynecological emergency. The major risk factor for this is tubal damage, say secondary to infection or surgery. We mentioned that the presentation of ectopic pregnancy can vary from mild pain right through to massive hemodynamic compromise and collapse. We've also shown that while ultrasound can be very helpful and give a definitive diagnosis either way, there are situations where you cannot be sure about the diagnosis. And in this setting, it's important to do repeat ultrasounds, serial beta-HCG and progesterone, and frequent re-examinations. Finally, we've considered some of the important medical and surgical options for the management of ectopic pregnancy. And I'd like to just leave you with this last slide to say that, once again, any woman presenting with a positive pregnancy test and pain should be considered to have an ectopic until proven otherwise. So that's it for this podcast. Thanks for listening, and see you soon.